discussion on COVID-19 treatment updates, the pharmacological treatment updates, and updates on whether we are using convalescent plasma therapy even as we manage our patients. Today we will be having Professor Omonga, Professor Anzala, and Professor Matilu Mwau addressing us. Then we'll have the question and answer session after their presentations. For CPD points, for anyone who has any challenges, kindly email us on knhcpd@gmail.com. Otherwise, I will give the platform to Professor Omonge.
Thank you for the invitation. I will briefly go through the drug therapy of COVID-19. I hope I'm clear enough.
Yes, Prof, we can hear you.
Good. So I'm trying to advance my slides.
The easiest would be to right click.
Yeah, it's not moving. Let's see.
When you right click,
my slides don't appear to be moving.
Okay.
Yeah.
Even when you right click, nothing happens.
My slides are, let me see if it. And why my slides are not moving.
Okay. The other option is to share them again.
Oh, okay, there. It's,
oh, yeah. Yes.
I'm there now. Good. So I think COVID presents a scenario where we'll see patients with diverse needs and diverse presentation. And for this quote from Sir William Oslas says, a good physician treats the disease, but a great physician treats the patient who has the disease. And we've seen the presentation of patients who are infected with SARS-CoV-2 varies from largely asymptomatic to post-symptomatic to patients who have mild and moderately and severe disease. So each of these patients will have very unique needs. So the outline of my presentation will be to look at the pathogenesis of COVID-19, then the clinical cause of the disease, the aims of drug therapy, and look at drug treatment targets so that we can examine the evolving treatment protocols. Now, this is a coronavirus, and it is enveloped a single-strand, non-segmented RNA virus, which has a surface protein, S proteins that are very important in terms of appreciating the pathology. It has other structural proteins, membrane, envelope, and nucleocapsid. Now, it's a virus that shows tropism depending on how the virus will attach on the different receptors. And the key for us to appreciate in SARS-CoV-2 is that it attaches on the SE2 receptor. The MERS virus, which was very similar, basically attached on cell surfaces that express the DPP4 or the CD26 receptor. Now, I have put this structure because it will help us understand the pathogenesis of COVID-19. From this illustration, when the virus SARS-CoV-2 infects the cells, it predominantly has a tropism for the lung and the GIT, although we have SE2 receptor in other tissue surfaces. Basically, when it attaches to the SE receptors in the GI, it causes infection in these epithelial surfaces. There is release of cytokines and chemokines, immune activation, which follows a very acute inflammatory process. Now, the disease may be severe if you elaborate a lot of these cytokines, and we see the damage principally caused in the lung in patients who elaborate on these inflammatory mediators. In patients who are diabetic, patients who are hypertensive, and patients who have cardiovascular disorders, and patients who are older, the SE2 receptor is upregulated. And so we've noticed that these are patients who are of high risk in having severe disease and having poor prognosis following infection. So what we aim to do in treatment of COVID-19 is appreciating that viral replication will make the virus available for more receptor attachment, is to decrease the viral load. We also know that there are inflammatory mediators that follow this immune activation process, and so we want to manage the cytokine storm and manage co-infections. I know a lot of lung infections may coexist in patients with previous pulmonary disorders and in patients who acquire new sepsis in the course of infection. And so management of this co-infection is important. In patients who are diabetic, hypertensive, who have cardiovascular disease, outcomes will also depend on good management of the comorbidities. So drugs have been tried in treatment of coronaviruses, and just like any viral infections, interferons that have broad activity against viral infections have been tried. It's also been found that the use of interferons with ribavirin gives a better effect. But as we are going to see in the cause of this disease, that there are targets that are useful for treatment of this when we see the enzyme systems that are found in the virus. Of course, neutralizing antibodies and vaccinations are not going to be part of my talk today. Now, the best understanding of the clinical cause of COVID and the risk factors that are associated with morbidity was seen in a retrospective cohort of about 200 patients in two Wuhan hospitals. And so it was good to understand what is the clinical cause of this infection. And what they did in these two Wuhan hospitals, in about 191 patients, largely a male cohort, 62% male, and a fairly advanced stage of a median age of 56. And this was a pulmonary hospital, so almost 50% of these patients had comorbidities. And the number of patients who were treated with antiviral drugs was 1 in 5. Now, what I want us to see in this chart is that there were two outcomes in the patients. There are patients who died and the patients who got well and were discharged. The mean time of death was 18 and a half days, and discharge was at 22 days. So when you compare the two populations of patients who survived and who died, there are a couple of things I want us to appreciate. That one, this was a cohort of patients with significant comorbidities. And that means that likely they were at a risk of an upregulated SE2 receptor presentation. And therefore, you can see the burden of death was 28%, way above the case fatality you expect in a population of patients who do not have comorbidities. Now, from the time of onset, we expect symptoms to appear between day 5 and 7 days. And you expect depletion of lymphocytes with nadir lymphopenia at around day 7. Now, the patients who had significant lymphopenia and had ongoing lymphopenia, a large number of these patients ended up dying. And so lymphopenia becomes one key prognostic index that we can simply use to follow our patients and to try and tell us who is likely to progress to severe disease. The patients who had lymphopenia but progressively reconstituted their lymphocyte counts represented the group that survived. Now, at this point where you have nadir lymphocytes count, you can see that on day 9 there was viral sepsis, and progressively this is a time where there is intense viral replication, and the patients elaborated inflammatory mediators. CRP, interleukin-6, ESR, serum amyloid A, ferritin were found to be high in this patient, and procalcitonin, if elevated, would be representative of concurrent bacterial infection. Now, we also noticed that D-dimers and fibrinogen were found to be elevated in this patient. And when you think of the pathology of COVID, we now think that there's a coagulopathy that also plays part in lung disease and, of course, disease in other sanctuaries. At day 12, patients had intense pulmonary symptoms and ended up with ARDS, and LDH was markedly elevated in these patients who had significant heart disease. And later on, day 15, acute kidney injury and acute cardiac injury was found to be in some of the patients who had pathology. Now, what I want you to see is that by day 15, the patients who probably had marked lymphopenia, had intense production of inflammatory mediators, had ARDS and from this cytokine storm, tended to require mechanical ventilation. And on average, the mean time for mechanical ventilation was day 15. And subsequently, we saw death in patients who are not, who represented the poor prognostic. And viral shedding went on a mean of 20 days and discharged about day 22. Also do appreciate that the outliers had viral shedding well into out of this range and would go on until the 37th day. So what we're seeing is the progression we anticipate. Now, one of the things I want us to appreciate is in this Wuhan experience, lopinavir, which is a protease inhibitor, antiviral drug, was given in day 14. So that will be important in our subsequent discussion, because we know that in the first 7 to 10 days, when you have intense viral replication, antiviral drugs would be very useful. And we know that the pathology of COVID is based on not only viral replication, but immunosuppression that follows this intense lymphopenia, and subsequently the inflammatory process that follows release of inflammatory mediators. So the right time to give viral-directed therapy would be in the early phase of the disease, where you have intense viral replication. And by the time you have lymphopenia, probably use of interleukin-2 and interleukin-7, which are more useful in differentiation and proliferation of lymphocytes, maybe consideration. Now, once this inflammatory response occurs and you have an aberrant host response to the viral infection, probably immunomodulatory therapy would be more useful. And at this phase, I think the antiviral drugs were not the more novel agents to use, and probably drug with immunomodulatory properties would be useful in this second phase of infection, where you have a cytokine storm syndrome. Now, to understand targets of drug activity, I think it will be useful to go through the replication cycles of the virus. We said that the SARS-CoV-2 virus has a surface protein, which is known as the S spike glycoprotein. The S spike attaches on receptors on the host cell. And we consider most of these receptors to be found in the lung, in the GIT. And so it uses this spike to attach. Now, the trimeric spike has two portions, the S1 and the S2 portion. And the S1 portion is important in binding in the receptor domain that will recognize as a ligand that recognizes that cell surface. So the virus will bind and attach to these receptors. And the split of the S1 and S2 receptor depends on certain enzymes. And for SARS-CoV-2 is an enzyme furin that makes it useful for then the S2 to fuse with the receptor. And using that co-receptor activity, you can then get the endosomal function of inserting the messenger RNA into the cell. And subsequently, you have non-structural proteins forming and then structural proteins as translation in this viral cycle. Now, I go through this to appreciate that there are certain things that you can do as you want to look at drugs that will target this virus. You can have drugs that inhibit attachment to these receptors. You can have drugs that inhibit fusion, whether you're inhibiting the transmembrane serine type 2 protease or other enzymes like trypsin, furin that will be found in these diverse viruses. And so then you can have drugs that inhibit protease activity that prevent the translation of proteins. And also you can have drugs that inhibit the RNA-dependent RNA polymerase. This is very similar to what we see in HIV, where we have entry inhibitors. We have, you can either inhibit attachment, fusion, you can inhibit protease activity, you can inhibit reverse transcription. Now the difference between this virus and HIV is that the SARS-CoV-2 virus has proofreading, and so it can correct for some of the mutation errors, and particularly that will be important when you're considering drugs that act like ARVs. So based on that understanding of cycle, we can see where we can target drugs. One, you can target drugs that will not make these receptors available. And one of such drugs that inhibits the interaction between the ligand and the receptor is Abidol or umifenovir. Then you can also have drugs that interfere with the proteolytic processing. We say that you need S1 for attachment and S2 for fusion, so that you'll have the acid endosome allowing entry of the mRNA material into the cell. So the drugs that do this function, and one of the drugs that has been found to use this mechanism is chloroquine and hydroxychloroquine, which will inhibit one, the proteolytic process that occurs in the receptor, two, the receptor glycation that is important for allowing fusion and attachment, and three, chloroquine is alkaline, and it makes the acid endosome change in pH, and so that will stop entry. So chloroquine has three clear mechanisms that will help in stopping the process of viral entry. But additionally, chloroquine has also immunomodulatory property. And that makes it an interesting drug to look at, because if it's going to interfere with if it's going to inhibit the cytokine storm, if it has some property of inhibiting lysosomal function and also inhibiting interleukin-6 production, then it gives chloroquine both an antiviral property in terms of interfering with viral entry, and also an immunomodulatory property and having some mitigation on the inflammatory response. Now, lopinavir ritonavir, which has been used as a protease inhibitor in HIV, has also found place in consideration here, because the translation of these proteins require a 3 chymotrypsin-like protease. And so if you inhibit, then the non-structural proteins will not be formed in this viral cycle. And then subsequently, one of the key drugs that is being tried with significant impact is remdesivir, with the second drug, favipiravir, which works likewise, that inhibits the RNA-dependent RNA polymerase that is required for translation to form the structural proteins that are required for assembly for the virus. So remdesivir works just the way tenofovir works. In fact, remdesivir is phosphorylated, and it looks more like tenofovir alafenamide, which is also a monophosphorylated nucleoside analog. And the way this works in SARS-CoV-2 virus is very similar to the way tenofovir and alafenamide works in HIV. HIV has a reverse transcriptase, and reverse transcriptase is an RNA-dependent DNA polymerase. So it takes RNA and converts it to DNA. Remdesivir is an RNA-dependent RNA polymerase. And so that could be is one area we can use to stop viral replication. However, in the second phase, where you have an inflammatory process, you can only target interleukin-6 and the other inflammatory mediators. And so we're going to mention tocilizumab, an interleukin-6 antagonist, which antagonizes the cytokine, the principal cytokine that is involved in cytokine storm. So when you have a new infection and you want to pick drugs, like SARS-CoV-2 has come at a time when it was not anticipated, and there's not, drug development takes a lot of time. So the strategy of treating a new drug is usually based largely on repurposing drug. You look at drugs that you know have worked in viral infections, and we know broadly interferons have broad antiviral properties. So in most viral infections, interferons are usually in the front line of experimental therapy. Then you look at your chemical library, and for SARS-CoV-1 and MERS, drugs that had been used for treatment of Ebola, like remdesivir, were tried. For SARS-CoV-2, we have a repertoire of drugs that have been used in other viral infections, and it is from this chemical library of about 61 molecules that one would look for treatment as you wait for research and development into new drugs, and also appreciating that once you identify the drugs, you must find the unique PK/PD and safety consideration for treatment of COVID. So how you go about this is pick those agents that you want to repurpose. You look at your library, and in this instance, there were about 61 molecules, like I've said. Now you want to repurpose them, and you know that the drug as a ligand binds on receptors on the virus to cause activity. So since we know the viral receptor docks, now we will then take the drugs we are repurposing them and see if the ligand will cause a significant effect on those receptor docks, and you have a dock score. Now for COVID, there are about 5 dock areas that we are considering, and what was done was to pick the molecules and see the response. Any score above 6.5 demonstrates efficacy in terms of that drug being used in viral infection. Now I want us to go through a few drugs like lopinavir that we've used, and it had a dock score in 5 areas more than 6.5. That tells you that it's an effective drug and potentially has an antiviral property against the COVID virus. If you go down and look at indinavir, it was also significantly robust activity at 4 dock sites, and ritonavir had also a robust activity at 4 dock sites. Now we have pre-existing combination of lopinavir and ritonavir. And these are molecules that then you must consider in terms of, are they efficacious? Yes. If they are efficacious, are they tolerable? And what are their adverse effect propensities? And so based on the fact that we know lopinavir boosted with ritonavir, both which have good docking properties, used in that combination will give you very robust effect in terms of inhibiting viral replication. Indinavir, of course, could work, but we know that its effect on the kidney makes it not the agent that you want to choose. And so appreciating that protease inhibitors that have been used in HIV will work by inhibiting the 3 trypsin-like protease in the virus, then we have a window to choose one of protease inhibitors. And inferentially, you can also use darunavir. And if we are considering the toxicities of ritonavir, rather than boost it with ritonavir, we can use darunavir with cobicistat, which has been used. Then how about the other drugs like remdesivir? I said that remdesivir is a nucleotide analog that is very similar to tenofovir. And just compare them, it has 3 robust docking sites. Tenofovir has two sites. Now, remdesivir is picked in this agent, 1, because it has 3 docking sites. 2, it has a very long intracellular half-life, just like tenofovir. But 3, it has very specific effect on the viral polymerase. And so when you give it, it's unlikely to have adverse effects on the patient because it has selectivity to the viral polymerase. Unlike tenofovir, that will also affect mitochondrial polymerase. And so remdesivir, favipiravir were chosen. Secondly, it's easy because the virus has proofreading for it to remove the nucleotide of tenofovir than it is for remdesivir. So this is how you pick drugs. Oseltamivir is a neuraminidase inhibitor, and the coronavirus does not have that enzyme. So that is why its performance is not very good. So based on that chemical library, you can see how you rationalize which drugs you're going to use. Chloroquine, of course, is the understanding of its mechanism of action and appreciating its antiviral properties in the past. How about considering receptor inhibitors of AT2? I think we're going to look at that and see, is it safe to use ARBs and SC inhibitors in these patients? Now, of course, there are many guidelines that come when you have a pandemic like this. And the Italian is one such from the Italian experience where they had to come with a criteria for treatment of patients who have COVID. And the treatment is indicated in patients confirmed with virologic diagnosis. And you only treat patients with mild symptoms if they have comorbidities and increased risk of mortality. Obviously, one would want to use drug therapy in a diabetic, in a hypertensive, in an elderly person who have symptoms. Otherwise, treatment would be useful in patients with clinical manifestations that are moderate to severe. So most of the patients who are asymptomatic and patients who are post-symptomatic may really not need drug therapy as demonstrated by this Italian group. And what they have as a simplified scheme of treatment and some of the drugs we're going to look at is that you have no antiviral therapy for the asymptomatic and patients with respiratory symptoms that are mild. But then when the patients are above 70 or they have moderate symptoms, then consideration of treatment with antiviral drugs is important. Remember, when we look at the course of the disease, it's going to be important that this treatment must be then started in good time. So a high index of suspicion and making a good diagnosis early is quite important. The Italians use a combination of lopinavir with ritonavir in this Lombardy protocol. And again, is combination therapy the way to go in patients with moderate to severe disease? And if so, which combinations will be worthwhile? I mentioned darunavir, cobicistate, and of course, in patients who are critically ill and severe disease, we now know that there have been issues considering the methicillin that has some anti-inflammatory effect. But let's be clear that with a pandemic situation, we've had lots of data from observational studies, and until we have concrete studies from randomized clinical trials, one has to be very careful that we follow our national protocols as we choose drugs that we use to treat our patients. Then, of course, remdesivir is also a preferred agent in these patients who have severe disease. So obviously, this is just an illustration of many of the existing protocols that we must rationalize even as we evolve our protocols. So is combination therapy useful? And you'll find clinical trials that have looked at combinations of chloroquine and azithromycin. Chloroquine is antiviral, has an immunomodulatory property. Macrolides are antibacterial and also have immunomodulatory property. But one needs to be very careful as you use combination of drugs that you remain cognizant of the fact that you have drug-drug interactions. And one of the key interactions in this combination is that they both prolong QT interval. One of the things that has made it a very key factor in considering patients who have risk for getting dysrhythmias when they use chloroquine. We've mentioned lopinavir, used with interferons, which are broadly antiviral, used with chloroquine. Oseltamivir has also been tried in this combination, but we said it's docking. It's not as efficacious in COVID virus. Remdesivir and lopinavir, both antiviral. And again, used in early phase, we must consider if there's potential cytokine storm, then obviously we are thinking maybe we need to use a drug that has anti-inflammatory property like tocilizumab or probably steroids. And basically, combination therapy has been tried. As we know, highly active antiretroviral therapy in HIV demonstrated that combinations work with synergy. So the story of hydroxychloroquine and how it, what made its use popular. One of the studies is this French study, and the many studies that came so quick, cohort studies and observational data. This was an open, non-randomized clinical trial of 42 patients, and it looked at 26 patients who were given chloroquine versus a control of 16 patients. The control was picked from patients who did not qualify for the studies or who did not want to enter the study. And the primary endpoint in this study was to look at virologic clearance in 6 days. And then secondary endpoint, virologic clearance over time during the study period, of course, then look at side effects. Now, I want you to appreciate this French study and some of the results that were used to popularize the use of chloroquine. In the 20 patients who looked at 75% got virologic cure, and in the 16 control, only 12.5% got virologic cure. So that tells you that use of chloroquine gave an impact of 6 times that of not using it. And when additionally chloroquine was given in combination with the azithromycin, compared to the patients who were on chloroquine alone, chloroquine with azithromycin was considered quite more efficacious. So a cursory look of this data tells you that chloroquine is very good and chloroquine azithromycin is perfect. And so let's go on and give chloroquine and azithromycin to all our patients. But there are limitations to this. One, is an observational study. 2, it's a very small sample size. 3, at the point of entry, the patients had variable viral load. And then in this study, they removed the 6 patients who are critically ill and were not included in the analysis. And there was limited follow-up, and there were no clinical safety and endpoints. So until that time that we have concrete data from studies that are very well conducted and well peer reviewed, it's going to be, one has to be careful on picking drugs and using them in treatment of our patients. So we need robust evidence from clinical trials. We need clearly established efficacy, tolerability, safety. We need to know the PK/PD. For example, chloroquine has worked in malaria. Hydroxychloroquine has been used in rheumatic disorders. Obviously, the drug targets different sanctuaries, and so you have to have clear PK/PD data for use of these agents in new infection, and then review the treatment outcomes. In the cytokine storm, there is an aberrant host immune response and inflammatory reaction, and so interleukin-6 antagonist tocilizumab has been useful agent that has been tried in this condition, and it works because inflammation is mediated by pathogenic T cells and monocytes that causes inflammatory response in the alveoli, and probably also induces a coagulopathy. So when you give tocilizumab, which is an interleukin-6 antagonist, you mitigate inflammatory storm, which is mediated by the interleukin-6, and so you calm the inflammatory response. Who do we use tocilizumab on? COVID patients who are high risk, who have high risk factors, severe disease, patients who have high concentration of interleukin-6, and of course in clinical trial settings. How about steroids? If we are to use steroids, we have to be sure that your patient is not having intense viral replication. The patient has been a pyretic for more than 72 hours, and at least has past 7 days from the onset of illness. You know, infections is one major challenge of steroids, and of course, patients with the risk of superinfection should be treated with care. But we know that there are studies that have suggested that in patients with worsening respiratory function, that dexamethasone has been useful. Again, of course, we need more data on steroid use. How about other inflammatory targets? One of the other autocoids produced in inflammation is angiotensin 2. Angiotensin 2 binds on the angiotensin receptor, AT1 receptors, and also AC2 receptors. And when it binds on the AT1 receptors, it causes vasoconstriction, you produce aldosterone, you prime your catecholamines, and you also have an insulin-like growth factor effect that will cause fibrosis and provide tissue injury. And that is why we use AC inhibitors in patients who have risk of vascular injury, such as hypertension, diabetes, and in heart failure. We want to inhibit the effect of angiotensin 2 on the AT1 receptors. But there's a reciprocal effect between AC1 and AC2. So if you block effect of angio 2, you tend to form angio 1 and 7 through mediation of AC2. But using ARBs would obviously then upregulate AC2 receptor, and you'll have more virus having an attachment site. So although the impact of SE2 is tissue protection because we do not have fibrosis, there has been fear of using ARBs in this patient, though it will mitigate the inflammation and fibrosis, with the thought process that you'll have more virus affecting. So, but you can mitigate this virus using antibodies, soluble SE2 receptors, or in patients who have a viral infection with shock. Angiotensin 2 has been tried because of its vasoconstrictor property and because it also occupies the SE2 receptor as part of treatment. So the place of angiotensin receptor blockers, SE inhibitors and SE2 receptors is also worth to consider. Remdesivir is a nucleoside analog. We said it inhibits RNA-dependent RNA polymerase, just like the other nucleoside ARVs. It causes premature chain termination, like tenofovir and other nucleoside analogs. And for COVID, we use remdesivir because it's a stable molecule. If you try the other ARVs, SARS-CoV-2 has proofreading, and it will take out this nucleoside analog. But remdesivir outpaces the proofreading activity. The other drug that can work is favipiravir. Resistance can only occur if proofreading improves with remdesivir. Concerning because we know that the nucleoside analogs are mitochondrial toxic when used until you damage 80% of mitochondria. Remdesivir is used for a short time, so you cannot damage that amount of mitochondria, polymerase gamma in the mitochondria. And then it is also very selective on the viral polymerase. So this is a very good drug with a very good intracellular levels in the airway epithelia, high genetic virus for resistance, and therefore has been used effectively. It's used for 10 days and the dose schedule is as I've indicated. Now, the other consideration is the use of anticoagulants because we think coagulopathy is part of COVID. The theory in terms of what is the mechanism has considered sepsis-induced coagulopathy. DIC has not been concrete, but it's DIC like coagulopathy, but there is no consumption of platelets and the prothrombin time tends to be conserved in this patient. And of course, consideration of thrombotic microangiopathy. And consensus now appear to suggest that patients who are on full anticoagulation, particularly those who have high D dimers, appear to do better than patients who have not been anticoagulated. So obviously, looking at the indexes of coagulation, that is one area we must be clear about as we evolve our protocols. Now, one of the good things that COVID has done to us is at least now we wash our hands with much more. Thank you. That's my presentation.
Thank you very much, Professor Omonge. It's a very detailed presentation. Now we'll give it an opportunity to Professor Matilu Mwalu to share his presentation on the same.
Good afternoon, everybody.
Good afternoon.
First of all, I don't have a classic PowerPoint presentation because our area of interrogation this time around was around convalescent therapy or convalescent antibodies, and is an area under development. And I think we had discussed that previously with Kenudia. But still, there are some things that I thought that I should quickly say around antibodies and around the convalescent therapy for people who have SARS coronavirus 2, if you'll indulge me, and I'll probably not be very many minutes, okay? Maybe the first thing for us to say is that classically, we all understand that the body responds to infection by, amongst other things, producing antibodies. And our normal understanding is that we begin by producing IgM antibodies, and then we get a switch where we begin to form IgG antibodies. And whereas this should be the classic thinking, we are beginning to learn very important lessons about this with regards to coronavirus, that maybe there are some things that we need to relook with regard to our classic understanding. For instance, from many studies, we can tell that seroconversion for both IgM and IgG antibodies may occur simultaneously, or the way we understand it, quite often sequentially, like it should, but sometimes simultaneously from the beginning. In fact, up to around day 4 from infection, you may find that up to around 30% of the people will have maybe even both the antibodies very early on in infection. By around day 14, you'll find up to 90% of the people will have both the antibodies. And by around day 19, 20 there, everybody has got both IgG and IgM. But there are studies that show that around day 19, 100% of the people have got IgG, okay? And it will have peaked by that time. And for IgM, the peak levels for IgM may be around day 20 to around day 22, okay? So some people seroconvert quite strongly. And there are some people who you'll find have got antibodies that are 20 times as much as others who are also infected, okay? The plateau levels for the antibodies may have no effect on the clinical presentation, but we can tell in some people that the peak levels of IgG and IgM may actually be higher in people who are sick or people who are more severely infected. So I thought maybe I should point out that. Then after 3 weeks or so, we begin to see a decline in IgM antibodies. So people who are less than 3 weeks into the infection have got higher antibodies than people who have infection that has lasted longer than 3 weeks. Then there's another thing that I thought I should say in this discussion. So whereas the gold standard that we use, like here in the lab where I work, the gold standard is nucleic acid tests. We now know that nucleic acid tests may miss a proportion of infected people, whereas those people have got antibodies, IgG and IgM, specific to SARS coronavirus 2 and are actually infected. In some study that I saw, 4% of the people were missed by nucleic acid tests, and yet they had antibodies that could have helped in detection of the infection. And the fact of the matter is that in future, this might help us in terms of testing when we are thinking about an algorithm that will help us identify people at the community level. Then, when now we are talking about antibodies for coronavirus, the ones that are most interesting to us when we want therapy are those ones that are directed at the spike protein. As you might have heard from the previous speaker, the spike protein mediates binding and fusion and is the protein that really likes the ACE2 receptor, okay? And antiviral antibodies that are useful to us will therefore target the spike protein and deal with its binding and its fusion. The spike protein has got 2 subunits. There is the S1 subunit. That one is the one that binds the ACE2 receptor. And then the S2 subunit is the transmembrane anchor and is the one that helps with regard to fusion once the particle has been internalized. You know very well that this is similar to the thinking you have around HIV, where you hear about GP120, GP41, and so on. This is the same kind of thinking if you want to visualize that, okay? Neutralizing antibodies can block the binding to ACE2. This is in theory. They can block the binding to ACE2 by targeting the S1 subunit, or they can block fusion by targeting the S2 subunit, okay? But there's a third thing that they can do. This is important. There's a third thing they can do. They can mimic fusion. They can cheat that fusion is occurring so that the S2 subunit changes its conformation, but is unable to facilitate fusion, all right? Now, when we think about convalescent therapy, okay, we are talking about people who have been sick and are recovering, and hopefully those ones have been infected, and hopefully they have developed antibodies that are specific to SARS coronavirus 2, okay? And we want to take their antibodies and give these antibodies to those people who are at risk of getting infected or people who are already infected, because we are trying to reduce the duration of signs and symptoms, or even to prevent mortality. So that is the thinking around it. And what we want to take from those people who are recovering from infection or who have recovered is we want to take their blood and take their a cellular portion of the blood, and then we hope that there are antibodies in there, all right? So, and we think theoretically that that should confer short-term immunity, which is what we need for SARS coronavirus 2, for a person who is at risk of getting infected or a person who is already infected. Now the question is, does convalescent therapy work? In other places, in other diseases it has. For instance, you might have heard about a disease that is called Argentine hemorrhagic fever. It's caused by a virus called Junin virus. For those of you who did virology in the 90s, you may remember one of those virologists who used to use the word Junin in the same sentence as the word machupo. Junin is a real virus, just like machupo. And it causes a hemorrhagic fever. And people have given antibody convalescent therapy to people who are infected, and the outcomes have been quite interesting. So the thing that we must remember when you look at those studies and that kind of approach for Junin virus, the first thing that we must know is that the neutralizing titers must be predetermined. So this is what you do. So you take a person who has been exposed to this particular agent, then you take their blood, and then you conduct some experiments to see what the titers of the neutralizing antibodies are, so that you can select from amongst the people with the highest titers, you can select that therapy to give to those people who need it, okay? So you must predetermine what the titers are, because you could demonstrate in Argentine hemorrhagic fever that when the titers were low for neutralizing antibodies, then the treatment was not very effective. But then when the titers were optimal, the treatment was quite effective. So you transfuse the highest titers. The other thing that you need to know is that if you transfuse this too late, then it doesn't work. So the therapeutic window must be determined before you give convalescent therapy in places where it has worked for some other diseases, okay? So for coronavirus, we know there are two main things that are probably happening that are important. The first one is, the first phase is where the tissue damage is occurring. The tissue damage is occurring, and you want to give convalescent therapy before tissue damage has occurred. The second part of the story is where the immune system is all over the place. The immune system is overexuberant. So you don't want to get to a point such as that before you give convalescent therapy. So you may have heard in our last presentation in some other forum, we talked about Ebola and the fact that when the people first tried convalescent therapy on Ebola, it didn't work. And when they went back to look at why it didn't work, they decided the first thing, the titers were too low. And therefore, if the titers were improved, the effects were much more interesting, much more acceptable. So has convalescent therapy been used for SARS coronavirus? Yes. There are some studies that we've looked at, although some of them had limitations. In one particular study, it seemed to have had some effect in SARS in people who are also on ribavirin and steroids. So it reduced the duration of shedding and the overall clinical presentation. So, but that study was confounded by the fact that in the other arm of the study, the people are also on steroids. So it was too complicated to interpret that kind of data, okay? So it has also been used in people who are severely sick with COVID-19 who have not really been given some of these things. And one of the lessons we are learning now is that high titers of convalescent plasma have helped reduce the duration of shedding. But unfortunately, for some studies I looked at, the mortality remained the same as if you didn't give, in that arm where you did not give the convalescent plasma, okay? So which was a bit of a disappointment. So, but remember, even for a disease like Ebola, monoclonal antibodies have been very effective, and we need therefore to think about monoclonal antibodies. When you are giving people plasma from others, there are things that you need to think about. The first one is that it's like as if you are transfusing. So therefore you have to match. You have to match the blood. You have to match the antibodies, okay, so that you don't get nasty surprises. And then remember also that sometimes antibodies will lead to what we call antibody-dependent enhancement of infection, because some of these infections require that fusion occurs or that the virus particle enters the cell. If you bind a virus particle with antibody, the cell will find it easier to internalize that virus particle, and some of that internalization is bad for you because you are not going to be able to destroy that particle. The same way that HIV, you don't want HIV to enter the cell for any reason. Okay, so sometimes the way to avoid this kind of thing is that you can select the specific antibodies, and there are ways of selecting that so that you have very pure, in quotes, antibodies. But sometimes us as researchers are able to make, instead of giving somebody plasma, we're able to make monoclonal antibodies, and we know how antibodies work. We know about the FAB portion and the FC portion and what they do. So we can make this specific, and people are making this specifically for SARS coronavirus. And it looks to me as though that this is a very promising approach in the sense that some of the effects that are found when you give plasma are avoided when you give monoclonal antibodies, and then you can really purify this like in the labs that you have, or in industry, so that you can have very, very concentrated antibody concoctions, in quotes. Okay, so but also the other thing I wanted to say as I come to a conclusion is that there have been specific neutralizing antibodies. There are actually several papers that have presented work where specific neutralizing antibodies have been isolated for SARS coronavirus 2. And they have even been shown in some animal experiments to have reduced the viral load in the lungs. And I think people are now thinking about going into human experiments, into clinical trials. And this is going to be an area that is going to be very interesting. Some of this work takes quite a bit of time when you're talking about clinical trials. When you look overall at the lessons we are learning from coronavirus, we think that, oh, my own hypothesis would be that this approach, these therapies, even if they are to prove effective, will probably find us at the tail end of this coronavirus pandemic, but they'll still have some role, because there are some schools of thought that say that, coronavirus is going to be with us for quite a bit of time. So for that school of thought, these therapies are something that one needs to pursue. So monoclonal antibodies and also just convalescent therapy is an area under development. The literature is just coming in, and is, for me, it's something that's of interest, but it's not something that I thought I can make 10 or 15 slides about it, because it's very new for SARS coronavirus 2. Thank you very much for the opportunity.
Thank you very much, Professor Matilumo, for your presentation. It's been very eye-opening. I'd like to give the platform to Professor Umu Anzala to also shed a bit more light on the COVID-19 treatment updates.
Hello, everybody. Sorry, I've been in and out. There are so many things to do. I hope you can hear me.
Yes.
Yes, I can hear you.
Okay, so thanks to Matilu, thanks to Omonge, my classmate, for a good presentation. What I'd like to add is that immunotherapy, use of antibodies, use of convalescent serum monoclonals, just the way Matilu has said, is an important area. And I'm sure those of you who are in surgery, those of you who operate on patients, some of you have been able to use monoclonal antibodies when you get a needle stick injury, when you are actually operating on a patient who happened to be hepatitis B positive. So this is an area of interest. It is an area that is growing. I can also tell you here and now that with HIV work that we are doing, we are now testing a vaccine that is designed to elicit broadly neutralizing and potent antibodies. But at the same time, had it not been for COVID, we would have actually studied another vaccine that is an infusion of monoclonal antibodies. Rather than inducing antibodies, you actually infuse monoclonal antibodies. So that study is actually upcoming, and ability also to be able to isolate antibodies. The antibodies that we were going to infuse, the initial antibodies were actually isolated from HIV patients who we call elite controllers. But then we did reverse technology from the antibody to go back, get the B cell, and then use that B cell in hybridomas to produce more specific antibodies. So that technology is actually available. But now coming back to the topic of COVID, I've looked at some studies that have been done for using convalescent sera, and meta-analyses that I've looked at that were published in May have actually found that the designs were substandard and so pervasive, and we cannot, using those studies, actually make any meaningful conclusion as to whether this convalescent serum works or not. And the reason why is because not all convalescent serum is the same. The issue has been when you recover plasma from recovered patients, one needs to, first of all, quantify the antibodies and also look at the quality of the antibodies. So not all antibodies are made in the same way. So there has been a problem in terms of standards. How do you quantify the antibodies? And then how do you also look at the quality of the antibodies? So the space is still moving. So in future, you will actually be able to see clearly standardized clinical trials, where once you actually recover the convalescent plasma, you will be required to quantify the level of antibodies and also to look at the quality of the antibodies and then come up with a dosage. Because as it is now, there is no proper dosage and there are really no proper standards of actually looking at that. And that's where these trials have been a bit of a problem in terms of really trying to understand which is actually the way forward. But there are many. There are over 80 active and planned clinical trials in the use of convalescent serum. And now, not to repeat what the other colleagues have talked about, I would like maybe just to revisit one or two things in terms of antibodies, so that we also appreciate that when we look at antibodies, the issue is that how do antibodies work? There are two aspects then. We talk of neutralizing antibodies, all right? And then we talk of binding antibodies. Of course, neutralizing antibodies will be the antibodies, for example, in terms of COVID, those will actually, antibodies that will actually bind to the ligand and totally prevent SARS-CoV from binding to its receptor on the cells. So those will be neutralizing antibodies. And then once you have that antibody antigen complex, then that particular complex will eventually be engulfed by the macrophage, and the process of cleaning up the system begins. Then there is also the level of binding antibodies. Binding antibodies are not necessarily bad, because we know of mechanism called antibody-dependent cellular cytotoxicity. This is where these particular antibodies may not be binding, but once a cell is infected, all right, that cell and these antibodies can actually bind, but you realize the FC receptor remains on the outside. Then macrophages and other follicular dendritic cell will actually bind from the FC receptor side of it. And then this will actually lead to cytotoxicity of those virally infected cells. So both aspects of neutralizing antibodies and binding antibodies may actually play a role in the use of this convalescent plasma. So this is the direction the study is taking. And then also there is another mechanism of action of antibodies, and this is called a complement-dependent cytotoxicity, complement-dependent cytotoxicity, where the antibodies actually bind onto an infected cell. And this approach then elicits complement receptors. I mean, elicits the complement system, because you know the complement system is also another immune system that we don't seem to talk about a lot, but also plays a big role in getting rid of intracellular infected cells, and this is where viruses belong. So as we appreciate antibodies, let's appreciate from the point of view of neutralization, from the point of view of binding, and also from the point of view of binding, looking at ADCC, antibody-dependent cellular cytotoxicity, and also looking at from CDC, and this is the complement-dependent cytotoxicity as well. So I will stop here because I don't want to repeat what Matilu has said, so that we can then maybe be able to answer questions. But also just to add, people might wonder, how do we make large quantities of monoclonal antibodies? Usually, people are now, you can actually use what we refer to as humanized mice. Humanized mice are mice that have been modified to actually adopt the human immune system, so that when you inject them with the proper antigen, whatever antibodies that will be produced will actually be human antibodies, which can then be harvested and be used as monoclonal antibodies. Now, mice are too small. People are now beginning to look at large animals that can be humanized, and they can humanize cows, they can humanize horses, they can actually humanize camels. And camels are beginning to become a better large animal to use because of size, but it's because we have just discovered that antibodies from camels are very interesting in the sense that they have only one arm, they are not double hooked, and that ability helps them really penetrate. These antibodies are able to penetrate cells, very, very well. So when you wonder how do we make monoclonal antibodies, is actually these processes of humanizing mice or humanizing large animals, and others can actually just be made artificially using hybridomas. Hybridomas are actually cells, B cells that you combine with immortalized B cells, and then from this, you can actually use the processes of fermentation to make large quantities of monoclonal antibodies. So I will stop there, and then we can go to answered question. Thank you very much. Over.
Thank you very much for your presentations. It looks like an extensive research is actually being done towards the management of COVID-19. And we all know that COVID-19 is quite new, and all of us are really trying to figure out how to even manage patients who are diagnosed with COVID-19. There's a question here from Pauline Kigo, which I will ask the panelists. Now, with all the research that is being done, what would be the recommendation for what should be used for COVID-19 patients currently? So which recommendations should we give to the frontline workers who are actually seeing these patients? Professor Monge?
I think my take is we should use the national protocols that are laid out for management of COVID-19 patients. But as we've seen, patients will present right through from those who are asymptomatic, those who are post-symptomatic, and those who have moderate to severe disease will obviously require some therapeutic intervention. In terms of using drugs, I think we must also stratify our patients to those ones who have high risk for progression of disease. And we must find a way of either using some of the inflammatory mediators that tell us that this patient is likely to be poor prognostic in terms of disease severity, and also in terms of pre-existing comorbidities. So the patients who are likely to require drug therapy are patients with moderate to severe disease, patients who have pre-existing comorbidities such as hypertension, diabetes, cardiovascular disease, patients who have pre-existing lung disease, immunosuppressed patients for one reason. I think those are patients who are likely to require treatment. Now we can only work in the context of this pandemic, and likely that we are going to have a significant burden on protocols that we standardize and use for all our patients. So which antiviral drugs are we going to use? In patients with significant inflammatory reactions, who will need steroids, if we will use steroids at all, if evidence is there on use of steroids. Do we need to use interleukin-6 antagonists? I think that's how one would look at it.
Thank you very much for that clarification that currently we should use what is on the protocol. I'd like to ask, especially to Dr. Irene Weru, who I can see on our panelists. So which prescriptions are we seeing, or what do we have currently available in Kenya and in the market that can be used for the management of COVID-19? Dr. Irene Weru?
Yes, Nancy, how are you?
Fine, thank you.
I think because many of our patients have been on the asymptomatic end, we've seen a lot of the azithromycin being prescribed, but not much of HCQ, at least not in Kenyatta. And we haven't seen requests for tocilizumab, but I think we are continuing to see increased requests for dexamethasone and enoxaparin. But I can ask my other colleagues to just respond in case I have missed any of those prescriptions, maybe Dr. Birichi or Kinuthia.
Dr. Rosalind Kinuthia or Dr. Birichi? Kindly unmute yourself. Even as they're unmuting themselves, and what Dr. Irene is actually saying in terms of HCQ, I'm seeing a lot of questions that people are asking. Are we still allowed to use HCQ for patients who are COVID-19? Because it's been deemed unuseful in the WHO, and from several articles, it's saying that there's more harm than good of using HCQ. So what would be your thought towards that?
In terms of use of HCQ, when you look at the mechanism of action, it's very novel in preventing viral entry. There's been concerns about toxicity, and particularly patients who end up with cardiovascular rhythm disturbances, QT prolongation. The challenge is also in the context of what other medication is the patient using. And remember, if a patient is using azithromycin, is using fluoroquinolones, the risk of ending up with a QT prolongation is much higher. So obviously, even as we use azithromycin, there must be bases. Are we using it because of its modulatory properties, or are we using it as an antibiotic? And which other drugs are we using? Chloroquine has been used for a long time. It's been reasonably safe, and it's been used in treatment of malaria. Hydroxychloroquine has also been fairly safe. These drugs cause QT prolongation even before. Now, the challenge is that the absorption of chloroquine is quite varied. They're quite independent variation, both in the absorption and metabolism. And then there are drugs with very long terminal half-lives. So we need good studies to be able to know that what are the safety for these drugs. So until that time that we have clear evidence from good randomized data, we still really do not have drugs that are known to be effective in treatment of COVID. And all we have are being used on the basis of clinical trials. In theory, the chloroquine will be very useful for treatment. In practice, we need the data to support.
Thank you very much, Professor Monga. Dr. Alfred Birichi or Dr. Rosalind Kinuthia, if you want to respond to any of the queries. Thank you very much. Based on the timelines, I think that the time I would like to give the panelists a few parting shots. They can give us the closing remarks.
Would you like me to start?
Yes, that's
Hello.
fine. That's
My
fine,
name is
Professor
Matthew.
Matthew.
I work for the Kenya Medical Research Institute, and I have my parting remarks have to do with the overall thinking around the monster that we are staring at right now. And I'm taken back to 13th of December 1968, before I was born, when a landmark paper was published by a person called Garrett Hardin in the journal Science. And the abstract of that paper was just one sentence. And the abstract said, the population problem has no technical solution. It requires a fundamental extension in morality. Now, here we are not talking about morality. This is not HIV and stuff like that. But I want to just tell you what he started off by saying in that paper that may be relevant to our overall discussions around SARS coronavirus, not in treatment because you already fallen sick, but before you get infected. So he says, at the end of a thoughtful article on the future of nuclear war, interesting, nuclear war, Wisner and York concluded that both sides in the arms race are confronted by the dilemma of steadily increasing military power and steadily decreasing national security. It is our considered professional judgment that this dilemma has no technical solutions, and so on and so forth. Then he tells us in his paper that he does not want us to focus on on the nuclear war story, but on the conclusion that those people who are speaking in that conference or in that article, what they were talking about, and that is there is no technical solution to the problem. I'm starting to become more of a prevention kind of person, although I'm a doctor by profession, because I'm looking at coronavirus and thinking it is conceivable that many of the challenges we are facing have no technical solutions, but they are looking at other solutions that are not medical in the classic sense of what we understand by medicine. So for instance, I can spend a lot of time thinking about convalescent therapy, whereas in my mind it's very clear that the biggest impact with regard to the pandemic is going to come from cleanliness, from sanitation, from sanitizing our hands, from wearing masks and so on. That said, I want to promise you that when we come back, we'll probably have some more substantial stories around convalescent therapy and monoclonal antibodies. Thank you very much.
Thank you very much, Prof. Professor Omuanzala.
For me, really, from my understanding of viruses and looking into the future, as we look at the current situation, maybe the immediate thing is we can manage the outbreak to ensure that those who are likely to get those who are likely to get moderate and severe disease are few as possible. But really the main push is for us to now start engaging in the immunology of vaccines, because this is where the push is going to be. And the discovery of an effective, accessible, and affordable vaccine will be a big game changer. So my request is that now, henceforth, that maybe would be the best direction to begin to take. And I say that because we have a lot of vaccine skeptics, but this is an area of concern for all of us. There has been very little discussion about adult vaccines, but really the whole area of vaccine has moved beyond just childhood. We must now be discussing about adolescent. We must be discussing about adults. We must be discussing about vaccines for the elderly. So as healthcare professionals, this is the direction we must begin to take, because when we talk of convalescent serum, when we talk of monoclonal antibodies, these are actually short approaches. But all these approaches are telling us that we need to look for something that is more permanent and more substantial. And for me, that thing that is going to be permanent and more substantial is actually going to be the discovery of affordable and accessible vaccine. So that is actually my parting shot. Thank you very much.
Professor Mwange.
I think from my last slide, you can see one of the benefits I think our patients will pick from COVID is being attended to by healthcare workers who wear masks, who wash hands, and who work in a slightly cleaner environment with which is with more sanitized surfaces. And I think as we look at the challenge of COVID, let's not forget the bigger challenges of nosocomial infections. And so as we continue washing our hands and wearing masks, our patients are more protected. Thank you.
Thank you very much for the presentation. We've gone through the COVID-19 treatment updates, the pharmacological and the convalescent plasma therapy, and our professors have given us a snapshot of everything that's going on. So for tomorrow, we will only be having one session from 10 to 12 p.m. on the experiences of managing COVID-19 patients. So kindly join us then. Thank you so much to all our panelists, to our presenters, and to everyone who's attended. There have been many queries about CPD. Kindly email us again on knhcpd@gmail.com. Thank you very much.